So right now we're seeing a patient who I've been taking care of for the past several months. She has significant lower extremity wounds. They were really infected and looked terrible and had a foul odor when I first started treating her. We did multiple surgical debridements, as I discussed in the introduction. Right now, we've achieved significant improvement in the wounds. She had a period of being on intravenous antibiotics due to cellulitis with some bacteremia. This has resolved. It's been a long process taking care of her. We have an amazing team. We have a private nurse that's coming 6 days a week. Right now, we're removing the dressings. The private nurse keeps me updated at all times. You can see she's in red. She sees the patient on a regular basis. We like to use chucks or blue underpads before we do this. She's much more comfortable in the reclining chair, even though it's significantly more pernicious on my back since I'm kind of scooting over. Removing her Crocs, which are great because at least let the feet breathe. Normally she's wearing Coban dressing. They do take it off in the middle of the night since she cannot tolerate it, but at least she has the Coban, which is a type of compressive dressing for at least 12 hours during the day. Right now, Ange has most of the supplies in a nice box that's organized. Unfortunately, she likes to torture me, the nurse, with pink gloves as opposed to blue gloves. But since we're in 2025, I decided to go with the times and wear the pink gloves. Yes, I should be bringing my own gloves, which I did not do for this visit, since I was bringing other things. Right now, we're moving the Curlex rolls to expose the legs. This is under the Coban or the compressive wrap, which you'll see later on. We both work together in tandem, which is very nice. Usually I don't have such help, but the family likes to have really good communication and collaboration, and the nurse really likes to be present when I'm there, so we have no lapses in communication. She's moving one side while I'm doing the other. We're taking a look at the wound. This wound was 7 times the size. You can barely see it. Unfortunately, the light does obscure it, meaning I'm using a bright light, which actually makes it very difficult to see, but the wound is significantly smaller. It used to be 3.5 centimeters by 3 centimeters by 1.2 centimeters. Right now, it's 1 centimeter by 0.5 centimeters by 0.3 centimeters. The left leg is more swollen than the right leg. However, both legs were about 60% more swollen prior to when I was seeing her. She has generalized edema or swelling of the legs with a little bit of heart compromise. That's why you need to use compressive wraps. There is a big myth in terms of not having too much compression. She probably does have underlying arterial disease. Using Coban is fine. You just don't want to have so many layers of compression, which can compromise the blood flow to the leg. I'm not worried about just using Curlex and with Coban. I probably would not do ACE bandage with Coban on this since we do not have a full arterial workup on her. So right now we're just probing the wounds, removing all of the detritus as well as the garbage. We're throwing it away. We'll be irrigating and washing the wounds. As you can see, we're just getting all our supplies ready. We're working at an awkward angle, even though we're working both together. As I said, it's much easier to do this in someone's bed or in a completely supine position, but we want to make a comfortable patient so she doesn't have to go back to the bed. I'm cleaning the wound with an irrigation called the Vash. It's hypochlorous acid. It's very good for removing any biofilm or any areas. At this point, we probably could just use straight normal saline solution, but since we have Vash, we're using it. It does get expensive if you're using it for several months. We're not really much worried about infection at this point since the drainage is very minimal. You can see a white layer, a flake, which is excess endoderm, which is a dermal matrix that we're putting on the wound, which is really filled in both wounds nicely in terms of the depth. The most important thing I look at in terms of wounds is the depth, not the width and length, even though the width and length has dramatically decreased. This was double the size, the one on the right ankle, which you're seeing right now, which the nurse is taking a picture of. We have remarkable wounds, very deep. Both wounds are very superficial at this point. Unfortunately, it's hard to see based on my camera angle and the positioning of our legs. As always, we take pictures and measure. This is very pathognomonic of both wound care as well as plastic surgery, both of which I like to label myself a cognoscenti. We're just going over different types of dressings. We can probably start migrating to every other day dressings. Right now, we're just commenting to the patient so she knows what we're doing. We're telling her that the wounds are significantly better, which she's very delighted. Usually the son and the grandson are present, but since it's a holiday weekend, they were not able to come today. So Ange, the nurse, is cleaning the legs. The patient gets a compound cream of different pain medicines and cocktail. So she's going to be putting on the legs. She does this very meticulously.
Tweedledum and Tweedledee?
It's a different mixture that was made at the pharmacy with a different cocktail by a pain management specialist. I don't know the exact components, but as a whole slew of different things. She's also taking medical marijuana gummies at nighttime, which has really helped with her sleep as well as her chronic pain. I'm a huge fan of medical marijuana. This is not something you puff. She takes a gummy. Sometimes people take a liquid form. It is not a panacea for everything, but it does help significantly. The nurse is really rubbing in the compound cream very meticulously. She's very careful. She's not impatient like most of us surgeons who would do this in about 5 seconds.
What's that?
But it's good to be really meticulous since the patient's more comfortable, doesn't have as much pain. There's nothing wrong with taking an extra few minutes to do it really well and do it right, which we're doing right now. Some of the angle of the feet are obscured due to my camera, which was bumped by the caregiver.
You could always come back on a rainy day, like you don't want to, if you do too much. I had a patient that
She's putting the compound cream on both feet. She has a lot of pain on the plantar surface as well. That's why she's rubbing in the compound cream. I know this seems very slow, but we're really spending time with this patient. When we first started seeing her, it took a long time to do the wound care due to her low pain threshold, but she's doing significantly better. She's extremely patient in terms of us taking care of her, and she's very happy with our progress. She follows instructions very well. She's super compliant. We just would like her walking to be more perspective, and she is getting physical therapy. They moved her from a previous assisted living facility to a new one, which is much more accommodating and has better ancillary services. The nurse Ange is still putting in the compound cream. Yes, she is babying the legs, but she is very meticulous. And as I said, it's much better to be really careful and not waste. Now, right now, I'm just getting the supplies that I'm going to be using for the wound care. We're going to be using Endodorm, which is a dermal matrix. Usually I use a collagen matrix, but today I've been using Endodorm, and I'm using it today. It's kind of like a white wafer. It works very well. When it starts drying out, you can either wet it or you can switch it over to a new product such as a gel. As we discussed in previous videos, I like to really dry wounds out. Most wounds that I see that are in a chronic phase drain severely with heavy exudate, which is drainage, which means it has bacteria and a biofilm. But once we can dry it out, you can start using different things. I like to, migrate to collagen products or other sort of matrices like this. This is, as I said, this is Endodorm. But when it comes really dry, meaning that this white wafer dries out completely and it doesn't get absorbed by the body, you can start migrating to either gels or ointments in the final stage of healing. She's almost there. Another option is you can wet the Endodorm. I think we're at the phase in the next few days switching over to Zeta daily wound care, which we've been doing, which I do for most of my patients to every other day since the drainage is not severe. It's very hard on the trunk wounds to do this every other day since you're always worried about fecal and urinary incontinence or contamination, meaning that we don't want poop being in the wound, but this is obviously in the leg, so we're not worrying about any sort of contamination. And she's not going to a construction site. Here, I put the Endodorm with gauze. I wasn't really prepared as I should have been in terms of having the Curlex roll or the cling, which is what I'm using right here. I'm wrapping this gently around the leg. Now, the key thing is when you wrap, you don't want to strangulate the leg, meaning you just wrap it as you need to. A lot of people will pull on this. As you can see, I'm not pulling. I'm just doing this as it needs to, meaning I'm not wrapping or pulling on it. It just holds it in place. When you strangulate the leg or you actually do it too tight, you actually can cut off blood supply. This is something you learn with experience. I have to teach the caregivers as well as a lot of nurses just to let it come out naturally. We do use a piece of tape since she has a tendency of taking the Coban off. The nurse is providing the tape to hold the cling/Curlex in place. We're going to go to the next leg, which is the right ankle, where the wound is significantly better. You may get a better angle, but it's hard with my camera angle to perfectly see the wound, but it's much smaller. I'm using just gauze on top. Normally I use an abdominal pad or some sort of padding, but there's such little drainage that we don't need to waste an abdominal pad. I'm using the cling once again. Unfortunately, the camera angle is cut off from me starting the foot. Anytime you do compressive dressings or wraps, you should also start from right below the toes, all the way up through the ankle and heel, through the shin, all the way to the knee. A lot of people will actually start at the ankle area, and that can actually lead to swelling because you're kind of cutting off the blood return, the venous return, meaning the blood flows back through the vein system. So you want to start from the toes all the way up to the knee area, which you can see I've done here. Unfortunately, you can't really see the angle of the feet. You just have to take my word for it. We'll use tape once again, as we did before, just to secure this dressing, if just in case we have to take the Coban off at nighttime, if she can't tolerate it. As you can see, there's good teamwork with both the nurse and I working in tandem, working together. And then the last layer is the Coban. This is like an elastic wrap. I'm very excited that it's this type of blue, which is a Duke blue. It works really well for compression. This will be the last layer that we do. Now, just like the Curlex, you don't want to wrap this too tightly.
I don't have an Ivy League education.
You see I'm starting from below the, below the toes, or actually rather above the toes, going through the ankle and heel, all the way through the shin. As you see, I'm not pulling on, I'm just wrapping it. Pull out after each 360-degree turn. I pull some more out, and then I wrap. I'm not trying to strangulate the leg. You don't want to have it too loose that it falls up, but you just have to do it kind of just right. Most wound care is like Goldilocks. That you want it to be perfect, meaning just like she wanted her porridge to be the right temperature. You don't want to have it too loose where it's falling off, but you don't want to have it too tight where it's strangulating. And we're going right up to the knee area, which will minimize pressure. It's very hard to go. I don't recommend going up above the knee or on top of the knee, since this can constrict her mobility. We can do the same thing on the other side. We're being symmetric with the color. We have another Duke Blue Coban, starting from just above the toes, through the foot, through the heel and ankle area, through the shin, and all the way just below the knee. As you can see, I have the Curlex all the way up to the knee area, just so the Coban is not rubbing on the skin. Some people do actually have a latex allergy, so this will minimize any sensitivity to the Coban, since most Coban does have latex.